Good evening, Dr. Nicholas and Paul, sir. Good
Yes,
evening,
yes.
sir.
Good evening.
Good evening.
We are just starting. Okay.
Yes.
A very good evening to all our delegates who have logged in and those who are in the line, and also our faculty who is joining from South India and already are there before us. Welcome to the World Bioethics Day. It's nice to see that 263 countries will be logging in to this program all over the world, and India is one of them. And today's theme of the World Bioethics Day, as they are used to have a theme separate for each year, this year being the non-discrimination and non-stigmatization. So on behalf of our patron, His Eminence, Oswald Cardinal Gracious, Dr. Anukant Mital, our Academic Dean of the Biomedical Ethics Center, our Associate Managing Trustee, Advocate Joachim Reis, and the Board of Trustees, we welcome you for this evening meeting on the World Bioethics Day celebrations. We have very esteemed and reputed faculty for this, which you'll realize when we introduce them. Discrimination and stigmatization is from times immemorial. And whether you go anywhere, on that matter, whether the time has changed with so much of enlightenment, technology, knowledge, still there are issues about discrimination and stigmatization. Be it the religious places, be it in the offices, be it in the community, whether you are speaking the language, we are not speaking the language, or different language, there are always these issues, whether you are going to help them, different community issues persist. This is one way we understand from the speakers how to go about doing non-discrimination and non-stigmatization. And before I take much of your time, I would like to introduce our first speaker, who is Dr. Princey Louise Palatty. She is the head of Department of Pharmacology at the Amrita Institute of Medical Sciences in Cochin. Am I right, Doctor?
Yes, yes.
Yeah. And
Right.
she has also worked in for 15 years in Father Mulla Institute and Hospital, College and Hospital. She is a pharmacist, being the head of Department of Pharmacology, and she is also a bioethicist, having done her course at the Haifa Institute in Jerusalem, and she is heading the South India unit of UNESCO chair in bioethics. Besides being a pharmacist, bioethicist, she has been also a paper writer. She has over nearly 200 publications. She has authored books, nearly over 7. She also has co-authored or written chapters in other books. She is an examiner in various universities, and she is keen on teaching so much that a lot of PhD students flock to her, I think 6 per year in pharmacology. So one of the branch in medicine I did not like very much was pharmacology, because I didn't have that much of big brain to absorb all this. I can imagine Dr. Princey must be how much gray matter she has to absorb all that and keep it, and that's why she called the prince of pharmacology. And with that short introduction, I would like to request Dr. Princey to give a presentation.
Thank you, Dr. Nicholas. It is, I would disclaim that I am more gray matter. I'm just sorry, I study by association and correlation. My neurons are less. Dr. Gireesh is the neurologist. He can, if he were to check it, he will find out for sure. Okay. Can we have my slides up, please? Yeah. We can put the slides from the center, or should I share? Yeah. Yes.
It's on the screen.
Yes, yes. So good evening, dear friends. At the outset, let me thank the organizers, and I'm really glad to be on this platform again with these wonderful people who run the FIAMC Center, which I had the great privilege to see way before the COVID. I have come twice or thrice to St. Paes College, and I have met with all these wonderful people. And I was eagerly waiting to meet Dr. Anukan Mital and Father Stephen, who was also part of this, and our good friend, Dr. Nicholas, and my dear friend and Dr. Giselle. I would have been happy to meet all of you all. But yes, today we are celebrating on this 19th October, there was another 19th October in 2005 when the 33rd Annual Assembly of the UNESCO gathered, and they adopted the Universal Declaration of Bioethics and Human Rights, in which there were 15 principles to be exact, and the article number 11 happens to be non-discrimination and non-stigmatization. So the World Bioethics Day is a day internationally celebrated to remind us that importance of bioethics, and we follow the theme of any of the principles. This we started from 2015, and that is why we have gone some of the years now. We started with human dignity, solidarity, and future generations was last year, and this year it is non-stigmatization and non-discrimination. And I should like to say this is just a primer, and we have my friend and colleague, a very great person who is there, Dr. Gireesh, will be joining us. So I will be taking only non-discrimination, and doctor will be taking the non-stigmatization. But I'm sure there may be a little overlap. So we will see it happen. Thank you. Next slide, please. So in this slide, can we just put that click there on the arrow? You would see the video.
Good morning, everyone. Time for a swim.
Yeah. There you see dogs, small dogs, big dogs, those with floppy ears, those are fluffy, those that are golden retrievers, Dobermans, and way different kinds of dogs are there, but you see how they are harmoniously playing with each other. They are not, and, they are not, you know, they are not of the same family. They have come together and they are in play. Can we stop? Next slide, please. Yeah. So this primer of this trigger. Next slide, please.
Good morning,
Next slide.
everyone.
Next slide. Yes. So in this, what I have tried to put is, we saw this picture. Now, instead of the dogs, if we had two Marathi speaking people, two Malayalis, five Punjabis, two or three Africans, South Africans, two Chinese, one Polish, two Germans, four Americans and two Australians. If we put them all together, what would happen? And they all be talking to each other, or they would plan up, and wouldn't they look down on others? This is what we usually do, but rather we should see how we can learn a bit from that first slide that we saw. We can learn it from the animal kingdom. I just put it as a trigger and as a thing. It's not, it's a very serious problem that we are facing, and we have to reduce it. And that is the reason why we have to uphold the principle of non-discrimination and non-stigmatization. Now, as I'm a woman and I'm speaking English itself is a fact that says, when you can speak English and you can be, many of the people can understand, other than speaking my Malayalam or Konkani or Tamil, right? So when you have a language that, or many can understand. So all these are things that help to differentiate and to discriminate. So let us take a look at the terminology. In the terminology, we say the Universal Declaration of Bioethics and Human Rights, which was adopted in 2005, it says that the discrimination and stigmatization are part of human dignity. And it is said that one cannot exist, they are intrinsically associated, and one has to be absent for the other to be present. So if there is human dignity, that means there is no discrimination or stigma there. Okay. So most of the time, next slide, please, there wouldn't be such a thing happening. So another aspect that they have told is that we have found that this discrimination has not come naturally. It is a social construct. It is a social construct, and this concept has to have been put up, and there is different kinds of discrimination that we have to know. Next slide, please. So we see in discrimination, there is positive discrimination, where one group of people are given benefits or favored. So discrimination is a negative impact that is happening, but at a time, we can also have a positive discrimination as also a negative discrimination, where someone is not allowed to access healthcare, where someone is not to get a particular favor or a benefit. There are, and opposite of that is positive discrimination. Now, in discrimination itself, we would note that there is implicit bias happening in intrinsically in discrimination. When we are looking, just standing around and looking around, also we see automatically that some things you allow for and favor and some you do not, like how I told a woman, so you may look down upon, or you are speaking English, so it's acceptable. So these are ways how discrimination is considered. In the next slide, please, we see here an air hostess. A simple example. Everyone knows to be an air hostess, if you're dark and not so good and do not have the vital statistics that are 36, 24, 36, you cannot be an air hostess. So there has been raised questions about discriminations in occupations and in employments also. Next slide, please. So as we continue with understanding of negative discrimination that is there, negative discrimination is also a point that you are seeing with respect to the negative impact of a stigma is more a labeling or a attribute, and that was brought out by Dept in 1963. The definition of stigma was given by him, and so negative discrimination is another aspect that we have to consider, where they are in want of some. Now, take our healthcare profession as such. In our healthcare profession, even we can see the minute we diagnose and label a person as HIV positive, you are labeling, and there is a disease that comes. Every disease is not associated with stigma, but there is a negative impact therein, and stigma is very severe. In the next slide, can we have the next? Yeah. This is what I would like to explain about the way how discrimination, it is like the pathogenesis of discrimination. So psychologists have measured it and understood in their studies and found that stereotyping is one of the first that happens to be, and this is actually a feeling. This is what they are associated with, and this goes on to becoming, so this is just a belief stereotype. Now that stereotype becomes a prejudice, which prejudice is always with a negative intent, and that prejudice goes on to becoming a discriminate, and that discriminate becomes a behavior. So from a belief, we go to an attitude, to a behavior that is seen. So this is very well characterized to understand how discrimination happens. And always within us, there is also, sometimes we are directly causing a discrimination, or sometimes indirectly also we are causing discrimination. So understanding this pathogenesis of discrimination is our, it gives the supply to your root to remove out this problem. Classically, I could explain stereotyping would be, we always feel women are a little less than men in their activities, maybe in their talents and all. So that's why we have this stereotype: women cannot do things as best as men. Then we see that women drivers are there, and you see that there are so many people driving across, men and women. One lady's accident you see, and you say, oh, no wonder it is a woman, and you have that prejudice taken in. And then you see that we have this always, you wouldn't take a car where the woman is a driver. That is called discrimination. In the next slide, please. In the next slide, we see we are all present in a group. So we have an in-group and an out-group. All those with similar tendencies becoming an in-group. And those with other tendencies, they are the out-group. So we always have showed disdain and no concern for the out groups, So when we are within a group, say all Malayalis get together, then, they become the group, you've seen how we suddenly speak in one language, the people in amongst a group. So that is what, we should be mindful of the others. So these are points that I would just like to reach. Next slide, please. In this slide, we are looking at how exactly we are bringing about the, what is the cause for this kind of discrimination occurring. So one of them is a confirmation bias. Like I told you, when a woman gets a driving accident, there were so many women drivers who went without any accident, but only the one who got an accident, and then you say that, oh, there, see, it's a woman who got accident. There were many men also who had the accident, but you take it as a confirmation bias. Also, we are called as cognitive misers because we don't want to see. Do you know what is the number of women drivers? I'm sorry, I'm taking this as an example to explain. How many women drivers are there total and how many are getting actual accidents? You don't see more accidents among women. Sorry. So did you go to see? No. But we have this attitude of stereotyping. And so we discriminate. So we are cognitive misers. We are not looking for the real-time situation. That's why we are called as misers, cognitive misers. And we have also the in-group bias. If it is all men, they will always look. If it is all women, they will always look with disdain on the others. These men, they drink and drive, like that. So there is also another factor, that is ultimate attribution factor error, that is also included, that can be put as attribution factor. Also, we have outgroup homogeneity. That is also another way. And the last method is the scapegoating. We always need someone to blame. And we always put, if somebody is robbing, we would always think it is someone with a bad character. And if you understand that he is of a minority or of of a caste, then immediately it is accepted. So that is how you do scapegoating, as said. Okay. In the next slide, we see, so we as human beings, we have freedom to have an equal society, to have a complete, excellent potential to show our full potential. But this freedom is encroached, and that is why we need rights to achieve and maintain our freedom. And in discrimination, as we see, it is because of many aspects of can lead to discrimination due to race, the nation of your origin, your political opinion, your sexual orientation, your gender itself, your language, your creed, and also color, all ethnicity, everything brings out. In fact, in today's day, if you have heard the word microaggression, have you heard the word microaggression? It is a commonplace behavior where we are always having a little inherent discrimination in all aspects. Next slide, please. So we are looking at our human beings. Our differences set us apart. How do our differences set us apart? That is why we are unique. That is why we are different, and that is what makes us. But our uniqueness is what makes you vulnerable, and that uniqueness is used to discriminate you. So at the same time, we can also say that we are more alike than we are different. That is also an aspect that is seen. Okay, next slide, please. Yeah, this discrimination also happens because of the huge asymmetry that is happening. Asymmetry may be because of socioeconomic, very commonly, because of knowledge and skill, because of benefits and burdens. And so these all perpetuate our discriminating attitude. Next slide, please. So we have this frog in the well kind of attitude. We think we are the best and all the rest are nothing. So this frog in the well attitude of ours has to be first deleted and wiped out. Next slide, please. And so we see we have to bring a remedy to this discrimination. One of the remedies that we can bring out is bringing empathy. When you feel for the other person, automatically you will have tolerance and there won't be discrimination. You accept the person as he is, and this is called as social inclusivity. We are a pluralistic society with multiple religions, multiple races, all and different socioeconomic stature with different levels of education and people. And we have to be inclusive. When we say inclusive, it is how many are disabled, how many are having different orientation, sexual orientation. We are looking at, so we have to say we, us. We cannot say, in that itself, we are making an affirmative language is coming through that is discriminating. Our language helps in discrimination. Unknowingly, unconsciously, you are discriminating. So we have to be very careful, and that is one is empathy. Another is education, how to bring out the awareness of such aspects, and so we do not show such negative behaviors. Another is equity. If you that asymmetry that is there can be corrected, then automatically there will be no problem of discrimination. Another way is if a patient is having HIV/AIDS or patient had COVID in our COVID times, we would hate to be called COVID because everybody would shun. That stigma had arisen. Now today, HIV/AIDS is so uh, it is common, but it is so good in therapy. When it started in 1986, when the first HIV case was discovered in a sex worker in Tamil Nadu first time, that time it was like a death sentence. But since then, we have evolved and we have got many antiretroviral drugs. In fact, we can't say it is cured, but you have a very low there is U is equal to U. That is, we have almost cleared out the disease, but we cannot say it is negative. But we can, in fact, there was only 7 people with HIV/AIDS has been considered cured of AIDS because of stem cell therapy in a drastic situation. But that is that cannot be put to general. Okay, so this is what. So when we have treated HIV/AIDS. Today, having HIV/AIDS, we are giving medication. There are NACO centers that supply the drugs, and they are taking the drugs right from the beginning. Pregnant mothers are also given therapy with their testing and immediately. So now, although AIDS is there, it is not a stigma because you can live a complete life. So, but still the stigma continues not only among doctors and the community. So let us as doctors and healthcare professionals, let us first realize and understand and give this meaning of using science and education to tell that, yes, it is a treatable disease. You don't have to worry about it. So also with leprosy, isn't it? Or TB. And about mental illness, that is another area that can be considered and importantly, and that discrimination should be avoided. So we can use empathy, education, equity. Also, we have training to remove our intrinsic and implicit bias that is inside us. And also, we should have non-judgmental care. And we should also look for tolerance. Our body and mind should be able to tolerate. And this tolerance is very, very important. This culture of developing tolerance. We are so intolerant, you see. You can see whether you're standing in a metro or you can just take a look aside, you will see it happen, right? Next slide, please. So we are looking at making an equal society where there is no discrimination. And this is no discrimination, equal society is not just a box that we have to tick. It is an actuality that has to happen. Next slide, please. So we see that when we do positive discrimination, it can tackle a superficial specific problem, but it is trying to legitimize the cause of social justice. By this, I would give you an example of our Mandal Commission that has put to help so many SC, ST, OBC group of people, and many lakhs of people have climbed the social mobility ladder, and they have been, taken out of this. So that is what is meant by positive discrimination that has happened. Next slide, please. And we are looking at civil rights. So to maintain this, we have civil rights. So civil rights has happened since 1886, but it was only in 1964 that we had the equal pay. Equal pay, right? So that happened only in 1964. Next slide, please. This is the anti-discriminatory act that is there, has an enforcement. So this anti-discriminatory law and anti-discriminatory law enforcement, that has to be enforced and implemented with penalty. Otherwise, it will not be corrected. So these are all part of the remedy. Next slide, please. This is just to show the aspect of discrimination. Next slide, please. Yes, here we see discriminated person. What are the things he would feel? And he would be losing out his job. He would not be getting a particular therapy. He wouldn't be accessing healthcare by himself. Yeah, LGBT people, like that. Next slide, please. So what happens to the discriminated persons? They would be having a feeling of hopelessness, a sense of shame, a hesitancy and reluctance to come out. And that leads them into depression and worsens their wish to live even. Okay, next slide, please. So friends, we have the Congress, this is in US, and other places that brings out various laws and policies to help us to prevent discrimination. Next slide, please. So we look at aspects where, the leave, the pay, and all can be, put together as a, it can be considered so that it is not affected. Next slide, please. This is GINA, that is Genetic Information Non-Discrimination Act. This GINA is necessary for us because oftentimes the employers will acquire a lot of knowledge and information from the employees. And this is not necessary. Why do we have to know whether the patient or the person, employee, has a marker for a particular disease? We don't need to know that. So that acquisition of knowledge, information of employees, all these are not necessary because they may not give him the next promotion, thinking that he may go into a disease, and so on, healthcare coverage, the insurance companies do this in a big, and nowadays, today, the main crux of the issue is one of the questions that is being told. You have an actual disease, existing disease is fine. Maybe you have the disease, but you know how cruel it is for a person who has a marker not having a disease, but has a marker present, and you are penalizing him for that by not giving the insurance coverage or not giving her particular a job or promotion and things like that. So this is Gina that has come in, and this many debates are occurring, and there is not yet an answer found to this. So these are the presently occurring debates there. So as we see, I'm showing you the to maintain non-discrimination, what are the things that has to be done, and these are specific areas. So this is pertaining to genetic information. Next slide, please. We have also pregnancy leave. And, people don't like to employ women in the workforce. But now the women have increased, and they do not like to take women in the workforces because of the same pay they are getting, but they'll be absent more often of the times. And they have pregnancy leave, etc. And so they have considered pregnancy leave should not be considered as any other. It should be tantamount to, and it should not be considered as any other. So that is what has been brought out here in this. So there are, in fact, one of my postgraduates, she became pregnant, but she continued her year without missing her time. She had her attendance. Of course, she didn't lose her attendance because there is a 25% attendance leave can be taken, and she did not take extra leave, the basic, and she answered in the same 3 years, she answered her MD exam. So this is what we should mean. Next slide, please. So this is again the timeline framework I have shown of the civil rights, the various timelines. Let us not go into the details, dear friends, but know that there are legislations coming through at various points. Next slide, please. Yeah. So here we see the workload, workforce, and the number of women that are coming up. And so when women work, are they getting equal play? Next slide, please. Are they getting equal pay? And women are not accepted in because they will have woman days leave, menstruation problems, children looking after pregnancy. So many leaves would have to be taken, and that is also present. Next slide, please. Yeah. So we also see that this is 1978, way back, so late, early, they had done this. Pregnancy discrimination should not be done. Next slide, please. This is another video. Can you play the video?
Well, Mr. Chairman, I'm fully in favour of this idea. We must have some positive discrimination in favour of women. Of course, it wouldn't work with the Foreign and Commonwealth Office for obvious reasons. I mean, we couldn't post women ambassadors to Iran or any of the Muslim nations. Right. Most of the third world are not so advanced as we are in connection with women's rights, and as we have to send diplomats to new postings every 3 years, this idea is obviously not for us, but I do applaud the principle.
Yes, me too. I'm all in favour of it. I think we need the feminine touch. Women are better at handling some problems than men, no doubt about it. Of course, we would have to make an exception as far as the Home Office is concerned. Women are not the right people to run prisons or the police. And quite probably they wouldn't want to do it anyway.
But you do agree with the principle?
Oh, yes, no question.
Peter? Well, yes, the same applies to defence. Alas, all those admirals and generals. And it wouldn't be possible, of course, to appoint a woman as head of security, for instance.
M would have to become F. Yes, defence is clearly a man's world, like industry and employment. All those trade union leaders. But what about the DHSS, John?
Well, I'm happy to say that women are well represented near the top of the DHSS. After all, we have 2 of the 4 deputy secretaries currently in Whitehall. Not eligible for permanent secretary, of course, because they're deputy chief medical officers, and I'm not sure they're really suitable for... No, that's unfair. Of course, women are 80% of our clerical staff and 99% of the typing grade, so we're not doing too badly by them, are we? And in principle, I'm in favour of them going to the very top.
Good, good. Well, I think the feeling of the meeting is, in principle, that we're all thoroughly in favour of equal rights for the ladies. It's just that there are certain special problems in individual departments.
Now, what about this
Yes.
question of the quota?
We can stop it.
Frankly,
So wasn't that interesting and funny talk about the various positive discrimination that they are looking at to tackle? Can't you see the very light vein that they have taken the various discrimination happening unconsciously there, isn't it? So it is, we have to get over this kind of a point. Now, this is another part about women that is there. Next slide, please. My time is reaching, so I shall come towards the end. And here I am bringing what is there in our Indian Constitution. The Article 15 tells us about there should be no discrimination for whatsoever the race. Next slide, please. This is the right to equality. This is present in our Article 14 to 18 of our Constitution. So everyone is equal before the law. Did you see that top aspect? So this is the equality before the law, and there is equality of opportunity that also comes through. And these are the laws that are, these are the basic parts that are present in the Constitution. Here we see the equality, this is the equality in the Indian Constitution that has been seen. So here, if you see to the right in this oval, you see all the various aspects of equality that as mentioned in the Constitution of India. Next slide, please. This is coming to our last slide. Here we see the various laws that have been enacted to prevent. These are the laws that have been implemented to prevent discrimination among women. So you can just read this. So many workplace harassment, sexual harassment, all posh, everything is there. Child remarriage, all these aspects are there for women. But now, as a healthcare provider that you and I are, how do we use non-discrimination principle here? So as I gave you the remedial issues, those are something. So I would like to inform you the take-home message is inclusivity. You have to respect the human dignity, and that is why we have to be inclusive and taking in everyone that we come across, not because of anything, but just because they are human. All right. So with this, I shall end my session. Thank you everyone for a patient hearing. My reference is from, next slide please. References from the UNESCO publications which are available. Just type UNESCO Chair Bioethics and you will get the, you will see the various publications that are easily downloadable from the net with respect to all of these aspects. So non-discrimination or human dignity, everything is given very, very clearly there. If there are any questions, clarifications I need to give, I'm ready. Or I would be also happy to hear some suggestions or share some discriminatory or how the non-discrimination was upheld from your end in some hearsay cases. Thank you.
Thank you, Dr. Princey. I will now request Dr. Anakan Mital, who could...
thank you, Dr. Nicholas. Thank you, Dr. Princey. My sincere, deep apologies for not getting in on time. I got so badly stuck in traffic that I couldn't get through.
Oh,
but very informative, very succinct talk, very interesting. And I'm sure it is in keeping with our theme. And I'm sure, I mean, of course, you are an expert. I have known you to be working in the field of bioethics for now, what, 12, 13 years now?
Yes. You
Uh,
were there with us. We started
yes.
in 2011 and I met you in 2012 in this
Yeah.
regard, right? Since then.
Right, right.
So happy to see you today.
Same here, same here. Thank you very much for accepting our invitation. And of course, now we'll be hearing about stigmatization, non-stigmatization from Dr. Gireesh, who is also equally experienced and up to date with what stigmatization and non-stigmatization is and how it affects the practice of humanity and humanism amongst us. I will now allow you to continue with the question and answer. And Dr. Nicholas Antao, thank you very much for being patient with me. Thank you.
No meeting can go on without you, Dr. Anathan.
Yes,
Hello.
sir. Everything can go on without me.
Pillar.
Hello.
Yeah.
Hello, sir. Are you allowing questions?
Yes, yes.
Yes, please.
Sir, I have a question to ask Princey ma'am.
Yes.
The question is this, that ma'am has told us about positive discrimination helping society. But there have been incidences like Khandamal and Manipur that is going on. Do you think one should investigate and go in depth and detail how true positive discrimination is going to help society or act against it?
Yeah. That's why I kept the slide. It's sort of in the name of social justice. Some things are being legitimized, and it is a superficial, not in every case. Okay. In some aspects of positive discrimination, it can be only a superficial solution to the problem. Okay. Not every case cannot be considered, but very often, in the name of positive discrimination, we are, in the name of social justice, we are trying to legitimize some negativity. Right. It can happen.
Yeah.
Yeah. You're very astute. Thank you.
Thank you, ma'am.
If there's no other question, you all can still ask at the end of Dr. Gireesh's lecture. It gives me a great pleasure and honor and privilege to introduce unique personality, as also Dr. Princey said. I myself have never came across any doctor who had 2 MDs, one in general medicine, neurology, and over that, after medicine, he became a surgeon. That's very unique, not only in India, but he is the only one in the whole of Asia. So we are pleased. When I rang him up to tell about our webinar and World Bioethics Day, I could not get him through. I tried twice, and now I wonder the type of service that he does, the type of community involvement that he does. It keeps him busy, but yet he called back and talked to me so nicely that pleased my heart so much. Besides being a neurologist and neurosurgeon, he has degree in complementary medicine, neuroacupuncture. He has done tremendous research in brain tumors, brain trauma, brain hemorrhages, brain gliomas, and also paraplegias. He is, despite of his life being occupied in service and surgery, he is always involved with the students, and they love him so much that he was voted as the best academic teacher in the institute. He has written books on brain death. He has written books on epilepsy. He has written books what families should know about epilepsy, and many. I may not be able to complete the list of these books, but here it is. He has been a teacher at the Madras Medical College and Kilpauk Medical College for over 25 years, and has received 21 awards, some of them being the best teacher of excellence, best doctor in the by the Tamil Nadu University, best community doctor and service for the poor and needy award. Besides this, he is an ethicist. He has done his course in Haifa University, Jerusalem, and also additional diploma at the Porto University in Portugal. Over to Dr. Gireesh to talk about non-stigmatization. Dr. Gireesh.
Respected Nicholas, dear friend, as well as Anu Kant Mital, who in fact spoke to me on twice or thrice to participate in this conference. And it is a unique opportunity, and I consider it as a golden opportunity, rather, to present onto this World Bioethics Day, along with, in fact, a pioneer in bioethics, Professor Princey. Okay. In fact, I learned from Professor Princey, actually, though Professor Princey is far junior to me, but I feel proud, to say that he has been a teacher in bioethics. Am I audible?
Yes.
Okay. Now, I'll just proceed to discuss on this topic, the non-stigmatization and non-discrimination as a part of Article 11. Now, as Professor Princey has highlighted this, the term stigma is originated in the ancient Greece, where it referred to symbols like burned into the skin of enslaved people and people judged as criminals or traitors. These symbols or stigmas suggested the person was blemished and that others should avoid and shun them. And the sociologist Erving Goffman refashioned the term in 1963 and gave its modern meaning. In a nutshell, stigma refers to any negative attitude, prejudice, or false belief associated with specific traits, circumstances, or health symptoms. Stigmatization is not a defined term in either of the declarations, but stigma is a distinguishing mark or characteristic, and stigmatize as to call by a disgraceful or reproachful name, to characterize by a term implying severe censure or condemnation. Stigma is being defined in Merriam-Webster dictionary as a mark of shame or discredit, and stigmatize as to describe or identify in opprobrium terms. Opprobrium meaning, of course, is something that brings disgrace. So stigma is a mark of shame, disgrace, or disapproval, which results in an individual being shunned or rejected by others. And this leads to discrimination. Discrimination is an unfair and less favorable treatment towards those who are stigmatized. So once you have a stigma, later on it can lead to discrimination and again further stigmatization. So both are interlinked. Now, National Alliance on Mental Illness has categorized the stigmas. Public stigma describes the overarching sentiment society is about the people with a certain trait. Like you tell a friend that you have a mental illness and they react by saying, oh, that's kind of scary. What if one of personality is trying to kill someone? Self-stigma. That happens when you accept public stigma. To put it simply, you may begin to consider your own traits or symptoms shameful and deserving of criticism, or believe you have earned a negative judgment because of them. Perceived stigma happens when you believe the people around you or the society as a whole judge you negatively for having a certain trait. Label avoidance happens when you distance yourself from a stigmatized group. You may, for instance, publicly deny having a specific trait or reject the treatment to avoid getting a diagnosis. Like you may avoid getting treatment for schizophrenia because you worry a diagnosis would cost you the custody of your kids. Structural stigma. This refers to institutional policies based on stigmatizing attitudes. The individuals who work for that institution may have no bias against you themselves, but the system operates in a way that puts you at a disadvantage. And we had seen this during the COVID-19 era. Health practitioner stigma. That means health practitioner stigma happens when a healthcare professional's belief in racial, gender, or other stereotypes gets in the way of their ability to provide effective care. Associative stigma that targets people connected to someone with specific trait. You may face criticism and judgment for choosing. I can have this. Sorry, for choosing to stay in contact with a person who has done something wrong by society's standards. Now, these are the types of stigma. Public stigma, self-stigma, perceived stigma, label avoidance, structural stigma, health practitioner stigma, associative stigma. It's by the National Mental Health Alliance. Now, what is the impact of stigma? It can have a long-term health and mental health consequences, like a reduced hope, low self-esteem, difficulties with social relationships, reduced likelihood of staying with treatment, more difficulties at work. A 2017 study by Oxel et al. Involving more than 200 individuals with mental illness over a period of 2 years found that the greater self-stigma was associated with poorer recovery from mental illness after 1 or 2 years. And it can also lead to social isolation, lack of understanding by the family, friends, co-workers, fewer opportunities for work, bullying, physical violence or harassment, health insurance that doesn't adequately cover your illness, the belief that you will never succeed at certain challenges or that you can't improve. So these are all some of the consequences of being stigmatized. Now, I'm just going to focus on certain areas where you find the stigma had been there, like HIV, mental health, LGBT, leprosy, COVID-19. Now, in these, I would like to highlight what measures the government of India, or rather the states, have taken, and what are the acts that have been enacted to see that this stigmatization is being combated or it has been prevented. So that is what I'm going to highlight very briefly. So I'll go by one in brief. HIV, you find over the years, the timeline is there, and you find the Human Immunodeficiency was acquired, Immunodeficiency Syndrome Prevention and Control Act 2017. I like to throw little light on this act and how it has prevented stigmatization. The HIV virus and the Acquired Immunodeficiency Syndrome Act 2017 came into force from the 10th September 2018. It's a very progressive legislation safeguarding the human rights, the legal rights, and reinforcing the constitutional rights for the people living with HIV. And, discrimination or stigmatization which lead to discrimination has occurred to HIV people. How? They have been denied access to healthcare services, segregation of hospital wards or isolation, early discharge from the hospital without a planned discharge, referral of patients with HIV because workers do not want to treat them, unwillingness to care for the patients living with HIV, disclosure of HIV status to family members or hospital employees, unwillingness among healthcare setting management and healthcare workers provide to acknowledge that stigma exists in their facilities, unwillingness to provide reasonable accommodation to HIV positive persons, denial of recruitment, promotion, and staff development opportunities, differences in employment compensation have been found, denial of promotion or staff development have been found, name calling and labeling of the physical abuse of HIV positive, isolation and seating arrangements, steps for the reduction is what we have to look into. And the main purpose of this act is to focus on the elimination of stigma and discrimination against people affected by HIV, reduce the stigma and discrimination in health service providers, education institutions, family, community, and society, create a workplace environment that encourages the prevention, treatment, care, promotes voluntary counseling. And these are the main purposes of the act. Engage the media and media personnel and see that promote what you can say the awareness about the HIV and AIDS, and provide a robust grievance redressal mechanism to be established at every facility level, state and the national. Now, discrimination. Now, in the act, there are certain sections which really protects these people. The protected person cannot be discriminated in public places like shops, public restaurants, hotels, and places of public entertainment. Subsection E of Section 3 of the Act. Subsection B of Section 3 of the Act. The protected person cannot be discriminated in terms of denial or termination from employment or occupation. Then subsection 1 of Section 3. Prohibition of HIV testing as a prerequisite for obtaining employment. Then subsection C and D of Section 3. The protected person cannot be discriminated in terms of denial, discontinuation, or unfair treatment in educational settings. Then the other one, subsection 3, subsection H of Section 3, prohibition of denial or discontinuation or unfair treatment, the opportunity to stand or hold public or private offices. Then the prohibition or denial of access to or unfair treatment in government or private establishment. Then right to movement, Section F, subsection F of Section 3, in fact shows that assures right to movement, which is a fundamental right entrusted under Article 19 of the Constitution. Then right to residence. Every protected person has been entitled right to reside in the shared household. Shared household includes a household where a person lives or at any stage has lived in a domestic relationship, either singly or along with another person. Then another section really shows that there should not be any segregation of people affected with HIV. Prohibition. Then any HIV positive person cannot be forced to disclose his or her status or any other HIV-related information except by an order of the court that the disclosure of such information is necessary in the interest of justice. The Act mandates informed consent as a prerequisite for HIV. Confidentiality should be maintained. Sensitization of all health workers. These are the proposed steps by the Act. Equal access to quality health service. And respect and confidentiality should be maintained with good communication skills, training of the health workers, and sensitization of them. Grievance redressal mechanism should be in place, and monitoring and evaluation of stigma and discrimination should be done. Communication campaigns should be done. Sensitization of key personnel of the workplaces, developing training programs for all the workers. Now you have a state ombudsman shall pass on. There will be a complaint where you can lodge a complaint if you find you have been discriminated or stigmatized. You can, within a period of 30 days, they are supposed to receive the complaint and act on it, preferably within 24 hours of the receipt of the complaint. And there can be a complaints officer, which can be there in every institution too. And they also are supposed to receive and what you can say, pass on to either state ombudsman or they take an action. Now, these are some of the penalties of the Act. Propagation of hatred or physical violence, imprisonment up to 3 months, fine up to 1 lakh. Failure to comply with the orders of the ombudsman, fine up to 10,000. Case of failure, up to 5,000 each day. Penalty for breach of confidentiality, fine or you can say which may extend to 1 lakh. So these are some of the governmental measures that have been taken to combat stigma for HIV. Now let us quickly go through the mental health. The Indian government has recognized the issue of stigma and discrimination against people with mental illness and has implemented various strategies. Let us see the key strategies. One is the District Mental Health Program. As of 2020, around 655 districts across India had been covered under this particular program, and they had found that there is a 40% increase in patients seeking mental health care in the districts. Mental Health Care Act of 2017. Again, this has decriminalized the attempt to suicide. The Act decriminalized attempted suicide, which had been punishable under Section 309 of the IPC. This was a major step in reducing the stigma associated with suicide. And the outcome is that, according to a report by Human Rights Watch, there has been a significant improvement in the legal rights and dignity of the people with mental illness since the enactment of the 2017 Act. Then the National Mental Health Policy. This policy advocates for the protection of human rights, better access to treatment, community-based care, etc. The outcome of this is that since introduction of the policy, the awareness campaigns have been launched, leading to a 15 to 20% increase in the number of people seeking mental health service, according to a report by NIMHANS. Tele-Manas initiative. That means tele-mental health assistance and networking access. You find within the first year of its launch, over 3 million calls were made to Tele-Manas, with over 75% users reporting a positive feedback on the service. Anonymity has been maintained, and awareness campaigns, as like the NIMHANS and NGOs, have led to Mind Matters. A survey conducted by YouGo India in 2020 found that after these campaigns, there was a 25% increase in respondents who said they were more likely to discuss mental health openly. School mental health programs, again, they are very, very effective. The outcome is, according to a report from the Ministry of Education, mental health interventions in schools have led to increased referrals to mental health professionals, with more than 2 lakh students availing of the counseling services across the country. Training and capacity building for healthcare workers. A study by Lancet Psychiatry highlighted that trained health workers reported a 60% improvement in their understanding of mental health issues and the stigma. So the Mental Health Care Act 2017, coupled with the school-based interventions, the district programs, have contributed to increasing the access of mental health services and reducing the stigma. So there is a stigma, and these are the measures that are adopted to reduce the stigma. So these are some of the references. The next is LGBT. Now you find LGBT, there are a lot of Supreme Court rulings that have come, which you find the stigma with LGBT is slowly decreasing. Now, one is the important one is this one, the NAS Foundation case of Delhi High Court, which decriminalized the homosexual acts and ruling that Section 377 violates fundamental rights. Then it was recriminalized by the Supreme Court in 2013. And thereafter, the right to privacy came in 2017 by Puttaswamy case, in which he has said very clearly, one's sexual orientation is also a right to privacy. Accordingly, you find decriminalization of homosexuality occurred, and the court ruled that Section 377, as insofar as it criminalized consensual sexual contact between adults of the same sex, is unconstitutional. That is the present state. So the court stated that sexual orientation is an intrinsic part of the individual's identity and should not be a ground for discrimination. So this is a very good judgment and was a victory for the LGBT people. Now the same-sex marriage, the court is still going on by judgment. No, so far nothing has happened. And the other very important one is about the transgenders. The Supreme Court ruled in April 2014 that transgender individuals can be recognized as a third gender. So again, the stigma has against slowly fading off. And the transgenders, the Indian Parliament passed the Transgender Persons Act 2019, which provides legal protection for transgender individuals. The Act prohibits discrimination against transgender individuals in areas such as education, employment, and healthcare. Well, the Mental Health Care Act also prohibits discrimination in mental health services with the gender identity. And also for public health campaigns, LGBT individuals have been involved. These are all what you can say removing the stigma. So the key initiatives, the government bodies like NACO collaborate with LGBT, like the Humsafar Trust, Sahodaran, to deliver the healthcare service and raise awareness about LGBT. So you find the decriminalization of homosexuality in 2018 and the recognition of transgender rights in 2014 stand as a significant milestone in removing or fading of the stigma. Though it still persists, but you do find that the earlier stigma is slowly fading off. These are some of the references which of these rulings by law has in fact helped the government itself as well as those suffering or those who are having LGBT. The one is leprosy. The other one, where the stigma is there, I'd like to just highlight few of the measures that have been taken by the government to remove this stigma. Hansen disease remains a public health challenge in India, despite its official elimination as a public health issue in 2005. You see? But now this is National Leprosy Education Program, Eradication Program. Now, these campaigns have improved public awareness about leprosy and reduced stigma in several regions. According to NLEP, there was a steady decline in new cases reported due to the program's efforts in early detection and treatment, with 88,000 new cases detected in 2019. The other one is the leprosy bill. Now, it emphasized the right to equality and non-discrimination for individuals affected by leprosy and their families. Then, another ruling for leprosy discrimination. In 2018, Supreme Court of India passed a landmark ruling. The court ordered the removal of all discriminatory laws that penalized or discriminated against individuals affected by leprosy, particularly in marriage, education, and public employment. This is again very, very important. And repeal of certain discriminatory laws, especially discriminatory provisions in laws related to the marriage, divorce, and public office have been targeted for removal. For example, leprosy was once considered, Hansen disease was once considered a valid ground for divorce. Such provisions are being abolished to prevent discrimination. This is a landmark court against a judgment and a law. Then a lot of awareness campaigns have started by the government, like the Sparsh Leprosy Awareness Campaign, and it has created quite a lot. The Sparsh Leprosy Awareness reached millions of individuals across country, contributing to reduce the stigmatization in several regions. And skill development programs have been developed for these people. And NLP annual report notes that over 12,000 individuals receive skill development training or financial aid for their rehabilitation. Then further, what you find, ASHA and various other organizations are giving as the health awareness to the workers. So the Indian government has taken multiple measures to reduce stigma and discrimination against individuals affected by leprosy or Hansen's, including legislative reforms, public awareness campaigns, healthcare interventions, and economic rehabilitation. These are some of the references which is quoted there in the slide. So these are some of the conditions: HIV, mental health, LGBT, leprosy. You find stigma is there. How this stigma has been reduced by the governmental measures as well as by rulings from the Supreme Court is what I have highlighted. And lastly, I'd like to talk about the COVID-19. The government of India adopted several strategies to combat the stigma and discrimination against COVID-19. These efforts include public messaging, legal measures, health worker training, and so on. And even as doctors, we are not even allowed in our own family after doing a duty, or you can say from the hospital when we return. We are supposed to have a separate room, see that all outside of the house, see that everything is removed, have a wash, put a fresh cloth, and then only enter into the house. You see? And the fear was so much that even if a person coughs, people get a shock. Now we can see this.
What?
That was the fear in the first and the second wave. If somebody coughs, they just run off. They get scared. That's it. So the lot of public awareness campaigns were against the Ministry of Health and Family Welfare launched various public awareness campaigns to address the myths and misconceptions in the COVID-19. Social media outreach programs were there. All of us have experienced that. Platforms like Twitter, Facebook, YouTube, Doordarshan, All India Radio, Arogya Setu app, that is a very good one. Evidence and also, or then legal and policy frameworks were there. Section 144 and law enforcement in certain outbreaks, discriminatory actions were there. This had to be introduced. That is to prevent mass gatherings where stigmatization, harassment occurred. And according to official government reports, after the legal interventions, there was a significant decline in reported cases of discrimination against healthcare workers and the COVID patients. For example, the number of reported violence cases against healthcare workers dropped by 60% in hotspot areas like the Maharashtra, according to data from the Ministry of Home Affairs. Health worker sensitization. So we have to sensitize the healthcare workers too. Community health workers, sensitization. Reports from the National Health Mission indicate a substantial increase in community engagement post-training, with 86% of trained ASHA workers reporting a change in the local attitude towards COVID-19 patients. Telecounseling helplines. The government launched helplines such as National Institute of Mental Health and Neurosciences, NIMHANS, helpline to provide psychological support. Mano Darpan initiative was introduced to support students, teachers, and families. And the statistics, according to the Ministry of Education, over 3 lakh individuals used the Mano Darpan service in the first 6 months of its launch. And RWA, Resident Welfare Associations, creating awareness. NGO collaborations, again not against it, to prevent stigma. And evidence in a report by UNDP India, it was shown that areas with strong community engagement saw a marked reduction in the stigmatization, with survey data indicating 20 to 30% reduction in the discriminatory attitudes in high-risk areas. And this is what, as a doctor, I had been training and donning and doffing what I did it for all the healthcare workers, more than 1,000 to 2,000 of SRM Medical College, as well as what I in a private hospital. Donning and doffing and personal protective equipment being done. And over this thing, I have given a lot of talks for aiming for the Lions organization, as well as for various other doctors also. Promoting positive stories, of course, in collaboration with UNICEF, the Ministry of Health produced video testimonials of recovered patients, which significantly helped humanize the experience and reduce stigma in several regions. So a mix of legal measures, community engagement, robust awareness campaigns, Indian government worked to address and reduce the stigma and discrimination against COVID-19 patients during the pandemic. Now, you find almost several doctors passed away. As many as 92 doctors died of COVID-19 to the first and second waves in the pandemic in Karnataka. Okay? And here, 154 doctors died of COVID-19 in Tamil Nadu. According to the data, a total of 1,596 doctors died, including 757 during the first wave, 839 in the second wave. In Tamil Nadu, 90 doctors died during the first wave and 64 during the second wave, numbering 154. Which was among the highest in the country. And after Bihar, it is 155, and Delhi 150, Uttar Pradesh 145, and West Bengal 145. I think we did a lot of services, doctors, and we can be really very proud. In spite of all the stigma, discrimination within even our own family, we were there on the forefront to save the patients. And let us see this. I'll end up with this one particular song, which highlights the services that we have done with the COVID-19 patients against all odds.
A certain call when the world must come together as one. There are people dying. Oh, when it's time to lend a hand to life, the greatest gift of all. We can't go on pretending day by day that someone somewhere will soon make a change. We all a part of God's great big family. And the truth, you know, love is all we need. We are the children. We are the ones who make it brighter than day. So let's start giving. There's a choice we're making. We're saving our own lives. It's true, we make a better day. Just you and me. Well, send them your heart. So they know that someone cares. And their lives
Secondly, the most very high final that we are there for the dog running and we can
turn that storm to bread, and so we all must lend a helping hand. We are the world, we are the children, we are the one to make a brighter day, so let's start giving. Oh, there's a choice we're making, we're saving our lives. Yeah, do we make a better day, just you and me? When you're down and out, there seems no hope at all. But if you just believe, there's nowhere we can fall. Well, we're learning to realize all that a change can only come when we stand together as one. We are the children. We are the ones who make a brighter day. So let's start giving. There's a choice we're making. We're saving our own lives. So we'll make a better day. Just you and me. We are the world. We are the children. We are the ones who make a brighter day. So let's start giving. There's a choice we're making. We're saving our own lives. It's true, we make a better day. Just you and me. We are the world. We are the children. We are the ones who make a better day. So let's start giving.
So that's it. I've set those places where stigma can occur, measures to combat stigma by the government for HIV, mental health, LGBT, leprosy, COVID-19 has been highlighted. That's it, brave, my dear brothers and sisters, on non-stigmatization. Thank you. Thank you very much.
Thank you.
Thank you, Anukant, Mital, and Nicholas.
Thank you, Dr. Gireesh, for such a wonderful, fluent lecture. It was just flow of words from your mouth, and at the same time, being a neurologist, you could combine the brain synapses to your talk, and it went so well. One practical question. I mean, it's all okay to say government did this, but how at the root level this is to be implemented?
Well, that is what the impact and outcome has shown, but there's a lot more to be done.
Yeah.
Even though transgenders has been considered as a third gender, but still there is a stigma attached. There is discrimination going on. But it is a change, the change has come from within. It is up to the public to start thinking about it and the change we have to do.
Dr. Anukant, do you have some question?
No, I think it was very succinct, very nicely put by both Dr. Princey and Dr. Gireesh.
Thank you.
I think the whole concept of this inclusiveness and learning how to not be discriminatory and stigmatizing is something which is very important now in society. Not only being politically correct, but also because of social norms, that we need to start altering our thought process and our behaviors subsequent to that, our emotions subsequent to that. And I think that's an excellent job that you've done for us, Dr. Gireesh and Dr. Princey. Thank you very much. Thank you.
After all, you are the light who led them the way, the path to do the bioethics.
Yes.
Thank you. Thank you very much.
Thank you. Any other question?
Sir, I just wanted to ask you one thing.
Yeah.
Dr. Gireesh said, good evening, sir. I just wanted to ask you,
Good evening.
in your opinion, does the patient who is stigmatized do better institutionalized for some period of time, or whether he's in society, that also counts, sir. Whether he's really moving in society. What is, in your opinion, your experience, sir?
Can you just repeat that question?
I beg your pardon, sir?
Repeat
I would
the
say,
question.
suppose a person has leprosy.
Yes.
Is it better for him to be institutionalized or in some community set up? Better, is it
Now, it
more
depends
advantageous
upon
for
the
him, sir?
severity of the illness, you know.
Yes, sir.
You know that leprosy is curable if diagnosed early.
Yes,
and
sir.
not waiting until they are crippled. So
Yes,
once the medicines are being started, I'm sure
Yes.
the bacilli or whatever it is, the quantum will come down. So infectivity period is going to be less, and then I don't think he requires isolation. That is what the repeal loss I said, you know, you be part of the
Yes, sir.
community.
Okay. Right.
All those discriminatory laws are all been repealed. In fact, the divorce is one of the commonest things for leprosy. Those who are leprosy, they can actually file for divorce. But now it is not. It has been repealed because it is curable.
Yes.
If diagnosed early, it has been curable.
Okay.
May I just add, as a take-home message, we as doctors and healthcare professionals, we have a role to play as a person of science, how we can bring out and tell that these are treatable diseases and they don't have the stigma attached, you know. So as a scientific person, when you and I and other healthcare providers tell it to the patients, and we ourselves practice, mind you, stigma is something we are also doing, and discrimination we healthcare professionals are also doing with related to healthcare aspects too, you see. So science is also a way of correcting this stigma.
As rightly pointed out by Professor Princey, I think many of doctors, we sit within four walls and, you know, consult practice, talk a lot. But, you know, it doesn't reach the public. I think today we have the YouTube and we have so many other platforms where each one of us can reach out to them and give positive messages about these diseases so that the stigma slowly fades off.
Very true. The great physician did that.
Yes, done.
Yeah, yes. He embraced the lepers and showed the way. Anyway, if there are no more questions, then I will request Mr. Anil Sequeira, my co-host, to give the vote of thanks. Anil?
Yes, thank you, Dr. Antao.
Yeah.
Good evening, ladies and gentlemen, doctors and...
Anil, just a minute. I have to just announce the competitions.
Okay.
Okay. Okay, can I just give me 5 minutes? Every year. Hello. Every year we have this World Bioethics Day competitions. Hello. We had several entries in the form of poetry, photography, and research papers on this team. And the judges were Dr. Sheryl and Dr. Giselle Paes and Reverend Father Matthew Coutinho. For the poetry, there were several of them. The third prize went to Mrs. Sharon Pires. Her title was Shattering Discrimination and Stigmatization. Second was Dr. Clavier D'Souza. The title was One and the Same. And the first one went to Dr. Sunila Nagwekar, The Shame of the Label. Then the photography session. Congratulations, the winners. Thank you for the others who did not win. Your poetries will feature in our newsletter, Touching Lives. So rest of the people will get to read and appreciate your talents. In the photography session, there were two. The second prize went to Nandini Cardozo. A beautiful photograph of the black dog willingly accepted the white dog rescue was adopted a few months back as a friend, and showing that color and individual differences don't matter when there is love in our hearts. And the winner was Sister Lavina Fernandez. The photograph, equal opportunities, boundless abilities, empowering all, and that disability is not a barrier, discrimination, but discrimination is. So that was the title of the photographs. And the last category was research paper. That went to Martin Fernandez. Martin has written on a research paper on non-discrimination and non-stigmatization, a study inspired by Article 11 of the UNESCO Universal Declaration of Bioethics and Human Rights. Congratulations, all winners. Thank you for your efforts, and I thank the judges for doing such a marvelous work. I know it was difficult for them to do, but they put up the best one because I also went to them. Now, can I request Anil to give the vote of thanks?
Yes, doctor.
Yeah.
Good evening, doctors, my dear alumni who've made it possible to come and attend this webinar, and also the guests who are present. Today, we all have taken time out and come together to celebrate unity, equity, and the courage to stand up for justice. Well, on this monumental occasion of the World Bioethics Day, on behalf of FIAM, it gives me a great honor to extend our deepest gratitude to all those who have made this event possible. First, a heartfelt thank you to our distinguished speakers, Dr. Princey and Dr. Gireesh, who have enlightened us with their profound insights on non-discrimination and non-stigmatization. Doctors, your words have not only inspired, but have sown seeds of change in the hearts of all those who are present for this webinar. This event wouldn't have been possible without the efforts of Dr. Mital, Dr. Antao, and Sheryl. Thank you very much. And lastly, to all those who have participated in this webinar, thank you for your presence, your willingness to engage in this critical dialogue. It is through our collective efforts that we can make strides towards a world where everyone is treated with dignity and respect, free from bias and prejudice. Together, we have taken another step towards a more inclusive and compassionate society. Let us, on the advice of Dr. Gireesh, he mentioned to us that we can, as lay people, and not only doctors, but as lay people, we can also spread this message through using social media. Let us continue to champion these values in our daily lives and inspire others to join us in this important cause. Thank you once again.
Thank you, Anil, for such a lovely vote of thanks, and we must thank. We cannot forget Sheryl for taking up the sole responsibility of organizing this. Thank you, Sheryl.
Thank you. Thank you very much.
Thank you very much.
Thank you.
God bless you.